السلام عليكم ورحمة الله وبركاته. Is my voice clear?
Yes, وعليكم السلام ورحمة الله وبركاته.
كل عام وأنتم بخير، عيد أضحى مبارك على الجميع. And so I will continue our thyroid gland disorders, and inshallah today I will cover thyroiditis and hypothyroidism and till congenital hypothyroidism. But let's start. And as I mentioned in every session, tools, files, and videos are not for redistribution, and also this is interactive sessions, so any questions at any time are welcome. You can stop me at any time and ask any questions. Also, scenarios need interactive discussions from all of you. Also, this is my YouTube channel, so each sessions after finishing I upload it, so you will find the previous discussions through thyroid disorders, this playlist. Also, my gifts will be presented in the thyroid disorders gifts, and some other tools will be presented in this YouTube channel. I changed some of my plans, so I general session 7, which is general revision and thyroid disorder, thyroid guidelines. I add another topic actually because we already do a revision since a few weeks. So I will discuss a new presentation about practical thyroidology. In this session, I will discuss actually the practical aspects of thyroid disorders. So I will not discuss the rare thyroid disorders. I will discuss only what you will see in your clinical practice, the most common disorders that we face daily. So I will not discuss, for example, resistance to thyroid hormone, resistance to thyroid hormone, or Hashimoto, for example. I will not discuss these disorders because this is a very rare disorders. But actually I will discuss amiodarone-induced thyrotoxicosis, for example, because it is a common to face in your clinical practice. And actually, I will discuss the practical points only, not the pathophysiology and the other tools that you will not see in your practice. So today, inshallah, I will cover thyroiditis, hypothyroidism, subclinical hypothyroidism, treatment of hypothyroidism, and congenital hypothyroidism. So I will cover thyroiditis, chronic autoimmune thyroiditis, which include atrophic or Hashimoto and Hashimoto thyroiditis, and other types of thyroiditis, which is very common, and a very recent and new subject, which is immune checkpoint inhibitor. Since 2018, each year have a question about immune checkpoint inhibitors. So this is a very recent topic, and each exam you will face a question about immune checkpoint inhibitor. And another very important topic, which is immune reconstitutional therapy. Also, I will discuss hypothyroidism and subclinical hypothyroidism, and also I will discuss a treatment of hypothyroidism, and I will focus about the combination of T4 and T3, because in the recent 3 years there is a question about this combination therapy for management of hypothyroidism, when choose it, how to choose this drug regimen. And also this is a new for fourth edition of Oxford Handbook, which is controversies in the management of hypothyroidism. And I will finish by congenital hypothyroidism. So as in each topic, I will. What about sound, Dr. Ahmed Shawki? Is my voice clear for all of you?
Yes.
Okay. As in the previous sessions, I before starting today's session, I will cover the summary from the previous sessions, the most important slides. This is one of the most important slide in my previous presentations. Actually, this is published by British Thyroid Association guidelines, published in 2014, and this is a U classification. U classification for thyroid nodule, and you should know what is the features suggestive of malignancy and features suggestive of benign thyroid nodule. For example, a lobulated outline or disrupted peripheral calcification or microcalcification or intranodular vascularity, or if the shape is taller than wide thyroid nodule. This is features of malignancy. But peripheral vascularity, peripheral eggshell calcification, isoechoic or mild hyperechoic nodule with peripheral halo, this is a benign features. In each year, there is a question about these features. And also, this is another very important table about the diagnostic categories from fine needle aspiration cytology, which is psi classification. You need to know what is the psi and what is the description and what is the action you need to do if the case scenario presented by different psi. For example, in each year they ask about if you have a case presented by thyroid nodule, and after doing fine needle aspiration cytology, it is report psi 3F. What is the next step? In this situation, you need to know that psi 3F, you need to do diagnostic hemithyroidectomy because the risk of malignancy is about 10 to 40%. And actually, in the previous exam, they ask about what is the risk of malignancy in specific psi categories. And usually they ask about the risk of malignancy in psi 3F. So don't forget that psi 1, this is a non-diagnostic. You should repeat fine needle aspiration cytology under ultrasonographic guide. Psi 1C, this is assessed fluid with insufficient colloid and usually correlate with the clinical and ultrasonographic finding. Psi 2, this is a non-neoplastic. This is a very important. And in this situation, usually just reassure and discharge. But in specific situations, you need to repeat fine needle aspiration cytology after 6 months, within 3 to 6 months, if there is a high suspicion of malignancy in the scenario. For example, if the patient has a previous radioactive, previous nickel radiation, or a family history of thyroid cancer, for example, or the patient is young, less than 20 years of age. So in this situation, we should repeat fine needle aspiration cytology. Psi 3A, this is a typical feature present, and we should repeat fine needle aspiration cytology. Psi 3F, as I mentioned, it is a follicular neoplasia, not follicular adenoma, not follicular carcinoma. This is a follicular neoplasia, and in this situation, we should go to hemithyroidectomy. Psi 4, this is a suspicion of malignancy, and we should go to hemithyroidectomy because the risk of malignancy is about 70%. And Psi 5, this is a diagnostic of malignancy, and in this situation, we should go to the surgical excision, not lobectomy, because the risk of malignancy is about 98%. Or we go to radiotherapy or chemotherapy for anaplastic thyroid cancer. As I mentioned previously, anaplastic thyroid cancer, the treatment of choice is surgery, but most patients cannot tolerate surgery because advanced stage of anaplastic thyroid cancer. So radiotherapy or chemotherapy is the best option in most of cases of anaplastic thyroid cancer. And in lymphoma and metastasis, also radiotherapy and chemotherapy is the best choice. Another very important slide, which is showing the mechanism of action of carbimazole and the propyl thiouracil. And actually, in each year, there is a question about the mechanism of action of antithyroid drug. Don't forget that propyl thiouracil inhibit the adenase type 1, which is responsible for conversion of T4 to T3 in the peripheral tissue. And this is unique for propyl thiouracil, not carbimazole. And another very important slide, how to differentiate between TSH versus resistant to thyroid hormone. And don't forget that Alpha subunit is the best biochemical test. And another one, a TSH response to TRH, a blunt response in the TSHoma, increase in the T resistant to thyroid hormone as a normal. And also another very important test, which is TSH response to T3. T3, if we inject T3 to a normal person, TSH will be decreased like resistant to thyroid hormone. But in the case of the TSHoma, no change in the TSH. And also pituitary MRI will we will find that in the TSHoma, most of them are a macroadenome. And so the best biochemical test is elevated alpha subunit. And from the previous sessions about Graves' orbitopathy, this is a very important slide, a clinical activity score, because the management of Graves' orbitopathy depends on activity and severity. How to decide clinical activity score. This is a 7-point score in which if the patient have 3 points, this is inactive Graves' orbitopathy. If 3 or more, this is active Graves' orbitopathy. Don't forget that 2 pain, 2 redness, and 3 swelling. Redness of the eyelid and conjunctiva, pain to pain, either pain on attempted upward or downward gaze, spontaneous or retrobulbar pain, swelling of the eyelid, conjunctiva like redness, and the swelling of caruncle or oblique. And another very important slide which decide how to manage Graves' orbitopathy is a classification according to the severity. Mild Graves' orbitopathy and moderate to severe Graves' orbitopathy, and lastly sight-threatening or very severe Graves' orbitopathy. Mild, in which there is one or more of the following feature: minor lid retraction, mild soft tissue involvement, exophthalmos, less than 3 mm above normal or race and gender, no or intermittent diplopia. Moderate to severe Graves' orbitopathy, this is 2 or more of the following: lid retraction more than 2 mm, moderate to severe soft tissue involvement, exophthalmos more than 3 mm, and inconstant or constant diplopia. Sight-threatening Graves' orbitopathy, this is a need urgent referral to ophthalmologist, this thyroid optic neuropathy, and or corneal breakdown. The management depends upon activity and the severity. And this algorithm just summarize how to manage a patient with Graves' orbitopathy. And at the start, we should restore and maintain euthyroidism. So if the patient is hyperthyroidism, we should render him euthyroid with mostly by antithyroid drugs. Advise people who smoke to stop. This is a very important step. Use artificial tears in most of our patients. Assess disease severity and or activity. If the patient have a mild Graves' orbitopathy, in this situation we should consider selenium for 6 months if mild and recent Graves' orbitopathy. If mild Graves' orbitopathy, we can give intravenous glucocorticoid. Don't forget that the management of Graves' orbitopathy nowadays involve intravenous glucocorticoid, not oral glucocorticoid. Intravenous glucocorticoid is better than oral glucocorticoid. So in mild disease, we can consider intravenous glucocorticoid if substantial effect on the quality of life. In a case of moderate to severe disease, in the case of active orbitopathy, we should go to the intravenous glucocorticoid. If inactive Graves' orbitopathy, we should go rehabilitative surgery if needed. If intravenous glucocorticoid for active moderate to severe Graves' orbitopathy not respond well to the treatment, in this situation we consider glucocorticoid with additional of mycophenolate, or if it is stable and inactive Graves' orbitopathy, after some time we go to rehabilitative surgery. If sight-threatening disease, we should go to the intravenous glucocorticoid. Poor response to the treatment, we go to the surgical decompression. So this is just summarize the management of Graves' orbitopathy according to the latest guidelines published in the previous year. So don't forget, this is a very important slide. Also, this is a multinodular goiter with compression. How to manage? Usually surgery. And actually, in each year, they will give a scenario, a patient presented by multinodular goiter with a compression manifestation. What is the next step? Surgery. Also, as in the previous sessions, I will cover some of the questions from the previous sessions. So I will start from the exam lab, and actual exam lab is very important source for solving question. During reading any scenario, you need to analyze the scenario and try to solve it before reading the options actually. 36-year-old woman was referred to the endocrine clinic with abnormal thyroid function test. She gave a 3-year history of increased sweating and anxiety. Sweating and anxiety should put in your mind hyperthyroidism. But 3-year history, this is a very long duration actually. So put in your mind hyperthyroidism or thyrotoxicosis, but this prolonged duration with non-treatment, you should review your differential diagnosis. Following an assault, and initially her symptom had been attributed to post-traumatic stress syndrome. TSH is normal, so we should exclude the primary thyroid disorder once TSH is normal. This is a very important. Free T4 is elevated. Free T3 is normal. What is the most likely interpretation of her thyroid function test? Yes, I see some of yours answered. We need more interaction. If anyone want to answer, please let me know. Actually, in this situation, as interference, we should, if we see only one thyroid function test is abnormal in a person like this, actually this is no thyroid symptoms or signs. Actually, as I mentioned, sweating and anxiety may be due to any other cause, and if it is due to the hyperthyroidism, duration of a 3-year history is a very long duration. So we should put in our mind as interference. Why not factitious thyrotoxicosis? As I mentioned, Dr. Ahmed.
Because TSH is normal.
Yes, TSH normal. We should exclude the primary thyroid disorder. We should exclude factitious thyrotoxicosis. We should exclude hyperthyroid, Graves hyperthyroidism or thyrotoxicosis for any cause. For example, the first test to be decreased in primary thyrotoxicosis will be TSH before free T4 is elevated. So factitious thyrotoxicosis is excluded because TSH is normal. Why we should exclude resistant to thyroid hormone?
Because both free T4 and the free T3
normal.
Be,
yes. In resistant to thyroid hormone, in the TSH HOMA, free T4 is elevated and the free T3 is elevated. Both thyroid function tests must be elevated in resistant to thyroid hormone. Yes. The same for TSH secreting pituitary adenoma. Use of combined oral contraceptive pills. This is estrogen containing pills, and actually will affect total thyroid hormone, not a free thyroid hormone. So this is a very important. If you see a scenario like this, please exclude LSC interference as a first step. And even if free T4 and the free T3 is elevated, the first step actually is exclude LSC interference, because LSC interference is more common than resistance to thyroid hormone and the TSH HOMA. This is a very important issue. So in any case like this, if the patient is present by mild hyperthyroidism symptoms and the free T4 is elevated and the free T3 is elevated, please exclude SC interference. Yes, Dr. Ahmed. So this is a case of SC interference. Another case scenario, a patient, 56-year-old woman presented with a swelling in the hair neck. So this is a thyroid nodule, which she had noticed by chance 6 weeks previously. The swelling had not changed the size since she first noticed it. and was completely asymptomatic. On examination, isthmus nodule with no lymphadenopathy, thyroid ultrasonography, the single 4.7 centimeter hypoechoic nodule. TSH is normal. What is the best next appropriate step in the management?
Fine needle aspiration. Because the size 4.7 cm hypoechoic and since 6 weeks previously discovered.
Yes. What about isotope scan?
If TSH is low, I will choose isotope scan.
Yes, this is the most important hint I want everyone to know. Normal TSH, no isotope scan. TSH is low, the next step isotope scan. So don't do isotope scan for patient with euthyroid or hypothyroid. Because in our practice we face a lot of these mistakes. A patient with normal TSH and someone order isotope scan. FDG PET CT scan, this is not the first option in any thyroid disorder, and actually as this is a thyroid nodule, the best option is doing fine needle aspiration cytology. Another very important question from a toolbook. This is a 35-year-old woman was referred by her GP to the thyroid clinic. Don't forget, this is a big a long question. Please go to the question, which one of the following is the correct description of the cytology? So in each case scenario, you can go to the head of the question, and some questions can be answered without reading the scenario. So which one of the following is the correct description of cytology?
D.
Which is?
Yes, D, non-neoplastic lesion.
Yes. So Cy2, this is a non-neoplastic. What is the cyclus for follicular adenoma?
Cy3F.
No, Cy3F is follicular neoplasia, not adenoma. Follicular adenoma is a benign condition. Follicular carcinoma is a malignant condition. So there is no Cy for follicular adenoma or carcinoma. There are a Cy3F for follicular neoplasia, which include adenoma or carcinoma, which may be adenoma or carcinoma. So we should go to the hemithyroidectomy to define, is it adenoma or carcinoma? What about non-diagnostic test? Which Cy for non-diagnostic test?
Taiwan.
What suspicious of malignancy?
Cy5.
Cy4. Suspicious of
Four.
malignancy is Cy4. Cy5, what is the Cy5? It is a diagnostic. So this is a very important, because in each exam you will find a question about the Cy. Another important question about yes. About 43-year-old woman was admitted with right lower lobe pneumonia. Once you see lower lobe pneumonia, you must put in your mind what? Non-thyroidal illness syndrome. This is a one. Another one, drugs that can interfere with thyroid function test. This is a very important. And was found to have AF. AF, put in your mind amiodarone and the effect of the amiodarone in thyroid function test. He had a history of bipolar disorder. What about the bipolar disorder? Lithium and the effect of the lithium about the thyroid function test. So in this sentence, you will face drugs that affect thyroid function test, conditions that may be affect the thyroid function test. Her menstrual period was normal, investigation TSH is normal, free T4 is elevated, free T3 is elevated. So this is a patient presented by elevation of thyroid hormone with non-suppressed TSH. The first step, please exclude the assay interference. So in the scenario they mentioned that assay interference has been excluded. Subsequent investigation is sex hormone binding globulin is elevated, is normal. It is thyroid hormone receptor alpha subunit is normal. Anti-TPO is negative. What is the most likely diagnosis?
Thyroid hormone resistance.
So this is a case of central thyrotoxicosis, TSHoma versus thyroid hormone resistance. As a interference is excluded, the alpha subunit is normal, so we can exclude the TSHoma. So the best one is thyroid hormone resistant. What about the lithium-induced hyperthyroidism?
TSH normal.
Yes, normal TSH exclude the primary thyroid disorder. Exclude the lithium-induced hyperthyroidism. Exclude the amiodarone-induced thyrotoxicosis. What about thyroidal illness syndrome?
Low T3.
Yes, this is known as a low T3 syndrome, in which T3 will be low, T4 will be low, TSH will be low, or mildly low normal at least, but T3 should be low. What about serpiginous injection of thyroxine?
TSH
TSH will be low.
Yes,
يبقى so in injection of thyroxine, iatrogenic thyrotoxicosis, TSH must be low. So this is a case of thyroid hormone resistance syndrome. Another case scenario, this is the last one question in this from the previous presentation. Thyroid hormone signaling can alter the individual tissue level based on the activation or inactivation of thyroid hormone. A lot of complicated paragraph. So which one of the following correctly describes the commonest 5-deiodinase enzyme present in the neurons and its role? Which one? In the neurons, don't forget.
D2. Type 2.
D2.
Leading to increased T3.
Yes, so in the neuron, this is a type 2 deiodinase enzyme responsible for
conversion T4 to T3 in neuron.
Yes, this is mainly. What about D1? Conversion of T4 to the active T3, and they present mainly in the kidney, liver, and muscle. And this will be increasing the hyperthyroidism. And actually, I will discuss it later when we discuss the ratio of T4 to over T3 for differentiation of endogenous hyperthyroidism versus thyroiditis or iatrogenic thyroiditis. And don't forget that D3 is responsible for conversion of T4 to reverse T3 and mainly presented in the placenta, and this is actually will protect the fetus from excess T3 or conversion of T4 to T3 through the placenta. So I will start my presentation today, inshallah. Thyroiditis. Thyroiditis means inflammation of the thyroid gland, destruction of the thyroid gland. So this is a case presented mainly by hyperthyroidism due to release of preformed hormone. TSH will be low with elevation of thyroid hormone, increased concentration of thyroid hormone, suppression of the TSH. What about the radioactive iodine? Will be low uptake, and this is very important because thyroid function test the same for thyroiditis, the same for toxic nodule or hyperthyroidism, a grave disease. So radioactive iodine uptake for thyroiditis will be low, and for other condition will be high uptake. Duration of hyperthyroidism in thyroiditis usually is short, 2 to 3 months. And don't forget that T3 over T4 is lower in destructive thyroiditis than the grave disease. And actually, in the next slide, I will cover this point. Hypothyroidism is common after the hyperthyroidism phase in most of cases, and permanent hypothyroidism can complicate some form. So most of cases of thyroiditis will return to euthyroid after some time. So the first stage is hyperthyroidism, the second stage is hypothyroidism, and later on the patient will be rendered euthyroid. A ratio of total T3 to total T4 can also be useful to differentiate between a Graves' disease or toxic adenoma versus thyroiditis. And actually, this is from the American recommendation, and I would like to hint about the Diagnostic type 1, which is responsible for conversion of T4 to T3, which is increased in hyperthyroidism. So in hyperthyroidism, more T4 will convert it to T3. So in endogenous hyperthyroidism, T3 will be elevated more than T4. So T3 will be elevated above the upper limit of the normal more than T4 in thyrotoxicosis caused by hyperthyroidism, in Graves' disease, in toxic adenoma. This is very important. And actually in the guidelines, they mention that the ratio will be increased at T3 to total T4 nanogram and microgram, more than 20 in Graves' disease and toxic nodular goiter, and less than 20 in painless or postpartum thyroiditis. Why this ratio? Because as I mentioned, a dehydrogenase enzyme type 1 is activated more and more in endogenous hyperthyroidism. And actually, thyroiditis, most of the cases need no specific treatment, just a beta blocker of the patient presented by tremor, palpitation, tachycardia. The glucocorticoid may decrease the duration of the condition, but are rarely necessary. So glucocorticoid not routinely used in the treatment of thyroiditis, just in a mild case. Postpartum thyroiditis, this is a very important topic in the exam, which occur in about 5% of the all postpartum women in the iodine sufficient area, and usually the presence of pain in the patient with destructive thyroiditis usually means the quervious thyroiditis, which is a post-viral thyroiditis. Most of thyroiditis are painless thyroiditis. Autoimmune thyroid disorder usually painless thyroiditis. Destructive thyroiditis occurs in significant number of patients treated with immune checkpoint inhibitor, and I will cover these drugs after a few slides. Overt hypothyroidism caused by autoimmunity, which is Hashimoto, which is a goitrous thyroiditis, and atrophic thyroiditis. Don't forget that Hashimoto thyroiditis, atrophic thyroiditis, both of these two disorders are autoimmune thyroid disorders. Yes, Dr. Saadiyya, I will cover this point again. Actually, in a case of thyroiditis, a Graves' disease, toxic adenoma, toxic multinodular goiter, postpartum thyroiditis, all of them, the patient will be presented by elevation of the elevation of thyroid hormone T3 and T4 with suppression of TSH. How to differentiate between these conditions? The best one is radioactive iodine ablation, for example. But in some cases, radioactive thyroid scan. A thyroid scan is not available in most of centers, and also in some situations, thyroid scan is contraindicated. For example, in the case of postpartum thyroiditis. How to differentiate between these two conditions? The American Thyroid Association guidelines published this paragraph. A T3 over T4 ratio more than 20 in Graves' disease and toxic nodular goiter. But don't forget that T3 by nanogram and the T4 by microgram. This is a very important issue, the reference and the reference to be used, the unit to be used. And if this ratio is less than 20, this suggestive of painless or postpartum thyroiditis. And as I mentioned, why T3 is more in the case of Graves' disease and toxic nodular goiter? Because as I mentioned previously, dehydrogenase type 1 is elevated, activated in hyperthyroidism, which is responsible for conversion of T4 to T3. So T3 will be more than T4 in Graves' disease and toxic adenoma. But in the postpartum thyroiditis and painless thyroiditis, T3 will be less than T4 because the thyroid gland actually secretes more T4 than T3. So a destructive thyroiditis or postpartum thyroiditis or painless thyroiditis, T4 will be more than T3. So T3 to T4 ratio will be less than 20. And actually this table is very important, the criteria of different types of thyroiditis. So you need to know which type of thyroiditis and how to manage. Autoimmune thyroiditis, what does we mean by autoimmune thyroiditis? Hashimoto and atrophic actually. Hashimoto usually thyroid enlargement, atrophic, this is in the stage of Hashimoto thyroiditis, so the thyroid gland usually is not enlarged. Postpartum thyroiditis in the first year after delivery, drug induced, the most common drug amiodarone and interferon alpha. Subacute or dequervian thyroiditis, this is a post-viral. This is a tender thyroid gland. So don't forget, in subacute or dequervian thyroiditis, the thyroid gland is tender. And this is a very important landmark or sign. The thyroid gland is tender, and in this situation, usually we give non-steroidal anti-inflammatory drug, and in some cases we give steroid. Another very important one is radial thyroiditis. This is extensive fibrosis of the thyroid gland. The thyroid gland is woody-like. The thyroid gland is like a wood. Radiation thyroiditis, this is a radiation injury transient thyrotoxicose, and don't forget that biogenic thyroiditis, this is a thyroid abscess. The most common organism is Staphylococcus aureus and Streptococci. And this is a pus, abscess, need antibiotic plus drainage. So this is a very important. I will discuss this thyroiditis in a lot of slides later on. So don't forget that suppurative, this is abscess. So the clinical presentation, the patient presented by painful, tender thyroid and feverish because this is infection. How to treat? Drainage and antibiotic. Thyroid function test usually normal. Subacute thyroiditis, this is a painful, like suppurative, tender thyroid. And usually the patient presented by arthralgia and usually generalized malaise and history of upper respiratory viral infection. And the patient usually presented by thyrotoxicose, TSH is low with elevation of the thyroid hormone. And how to manage? Non-steroidal anti-inflammatory drug. Autoimmune, which is Hashimoto or atrophic, usually the patient is hypothyroid. Some of patient is subclinical hypothyroid and rarely presented only by thyrotoxicose for transient time. Radial thyroiditis, this is a hard, woody consistency of thyroid, and usually thyroid function test is normal. So Hashimoto thyroiditis is associated with HALA-DR3. And actually in the session of thyrotoxicose, I mentioned this table and mentioned that Hashimoto thyroiditis is associated with HALA-DR5. And actually I revise this topic from a lot of sources and find that Hashimoto thyroiditis is associated with HALA-DR3. So please correct this. Hashimoto thyroiditis, Graves' disease, Addison's disease, systemic lupus, type 1 diabetes, all of them associated with HALA-DR3. Hashimoto thyroiditis, this is a non-tender thyroid enlargement, rarely presented by hashimotoxicosis, presented by low TSH with elevation of thyroid hormone, but later on the patient presented by hypothyroidism. Postpartum thyroiditis, this is a mild self-limiting disease. And most of patients of postpartum thyroiditis rendered euthyroid within a few months. Subacute granulomatous thyroiditis, this is a painful thyroiditis. ESR is elevated, usually presented by jaw pain and very tender thyroid. Dequervian means pain. And the treatment by non-steroidal anti-inflammatory drug. The patient presented clinical by hyperthyroidism, then euthyroid stage, then hypothyroidism, and most of cases at the end euthyroid, usually preceded by viral infection. And the last one is radial thyroiditis, which is invasive fibrous thyroiditis associated with IgG4 related disease like autoimmune pancreatitis, retroperitoneal fibrosis, non-infectious aortitis, and usually presented by slowly enlarging hard rock-like fixed and non-tender thyroid. And some cases need a drug like tamoxifen for this or corticosteroid in a very rare instances. So I will go to another question based of 5. This is from on examination. A 54-year-old female presented with a neck swelling. Once you see neck swelling, you should go, is it a diffuse thyroid swelling or it is a localized, which means thyroid nodule or cervical lymph node. Noticed over the previous 4 months. Clinically, the patient is euthyroid. The most important is doing TSH with is mild elevated. TSH is mild elevated. What about the T4? It is a normal. So in this situation, this is a subclinical hypothyroidism. What about the antimicrosomal antibody? It is a positive. What does antimicrosomal antibody means? This is anti-TBO. This is anti-TBO. Previous name is antimicrosomal antibody, but nowadays it is anti-TBO antibody. What is the most likely explanation for the patient goiter?
1. Hashimoto thyroiditis.
Why Hashimoto? Why not the Quervian thyroiditis?
Painless goiter. There is no pain.
Yes, the Quervian thyroiditis means a painful thyroid, tender thyroid, elevation of the ESR, elevation of the C-reactive protein. This is very important. What about the anaplastic thyroid cancer?
The age of the patient and progression.
Very aggressive.
Yes, mainly anaplastic thyroid cancer is a very rare, not common, and actually the patient presents by compression manifestation. So anaplastic thyroid cancer is not a common, not the only the age, but the presentation usually anaplastic thyroid cancer invasive cancer. So the presentation will be different than this. So don't forget that Hashimoto thyroiditis may be presented by a subclinical hypothyroidism. So what about the chronic autoimmune thyroiditis, which means atrophic or Hashimoto thyroiditis? Don't forget that Hashimoto thyroiditis is a painless, rubber consistency of thyroid gland, regular surface, and after doing thyroid sonography, some of sonarists mention that pseudolobules, not a true thyroid nodule, but pseudolobules in Hashimoto thyroiditis. So some, if the ultrasonography is not perfect, he can mention it is as a thyroid nodule, but this actually is a pseudolobule, not a true thyroid nodule. And actually Hashimoto thyroiditis is presented by subclinical or overt hypothyroidism, and in very rare condition may be presented by hashimotoxicose. Atrophic thyroiditis, most of the references mention that atrophic thyroiditis is the end stage of thyroid disease, end stage of Hashimoto thyroiditis. What is the investigation? The most important to diagnose Hashimoto thyroiditis is thyroid function test and thyroid antibody. And don't forget that the thyroid antibody, I mean that anti-TBO and anti-thyroglobulin. And here in the Oxford book, they mentioned that the anti-thyroglobulin antibody is positive in about 20 to 25%, but actually they mentioned that in this table, anti-thyroglobulin is positive in about 60%. But in the latest edition of the William textbook of endocrinology, they mentioned that TG antibody is positive in the 80 to 90% of the autoimmune thyroiditis. So don't forget that this number is not correct in the Oxford handbook. The most accurate one is William numbers. and the anti-TBO or antimicrosomal antibody is positive in about 95%, and actually it is mostly, in most of the cases, it is from 90 to 100% in the autoimmune thyroiditis. Don't forget that thyroid biopsy is not needed in most of cases, but in some very rare case we need to do it to exclude the malignancy, especially in a patient with Hashimoto thyroiditis, if there's a rapidly enlarging thyroid gland, to exclude thyroid lymphoma. And actually, if there is a nodule with specific criteria, we should go to fine needle aspiration thyroid. What about the prognosis? The prognosis is very good for all of types of thyroiditis actually. In the atypical situation where Hashimoto thyroiditis present with a rapidly enlarging goiter, in this situation we can give a high dose of prednisolone for a short time. 40 milligram daily may prove helpful for 2 to 3 weeks. Any unusual increase in the size of the thyroid in patient known to suffer from Hashimoto thyroiditis, put in your mind thyroid lymphoma, because the thyroid lymphoma is a rare, but the risk of thyroid lymphoma is about 70 double in the patient with Hashimoto thyroiditis. Other types of thyroiditis, which is a silent thyroiditis, in which the thyroid scan is low uptake. And this is a very important topic, which is postpartum thyroiditis. I already covered postpartum thyroiditis in the previous sessions, and actually I will cover it today, inshallah, and I will cover it, inshallah, in the next session after amiodarone-induced thyrotoxicosis. Postpartum thyroiditis, this is usually occurs in the first 6 months postpartum, and in another references in the first year postpartum. Clinically, the patient usually mild goiter with mood disorders. The prevalence from 5 to 7%, and postpartum thyroiditis occur in about 40 to 60% of the women who have positive anti-TBO. 25% of the cases presented by hyperthyroid stage in the first few months. Later on, the patient remained all patient go to the hypothyroid or euthyroid stage. But in most of cases of postpartum thyroiditis discovered in hypothyroid stage. Most of the patient of postpartum thyroiditis go to be euthyroid within 1 month, 1 year. So the prognosis of postpartum thyroiditis, because this is actually a question in the previous exam, they ask about the prognosis of postpartum thyroiditis. Most of patients will be rendered euthyroid, but 20 to 40% will be permanent hypothyroid. But most of patients with postpartum thyroiditis will be euthyroid. Of course, the postpartum thyroiditis will increase in the type 1 diabetes about 25%, or if there is a previous postpartum thyroiditis, the recurrence rate is about 25 to 50%. And this actually is a question in a previous exam. So in a previous exam, they ask about the postpartum thyroiditis recurrence rate, which is about 25 to 50%. And in another question in the previous year, they ask about what is the most likely outcome of postpartum thyroiditis, hypothyroid or euthyroid. Of course, it is most of patients will be euthyroid. The chronic fibrosing or radial thyroiditis, as I mentioned previously, this is a rare, intense fibrosis leading to induration of the tissue of the neck. Usually may be associated with mediastinal or retroperitoneal fibrosis, salivary gland fibrosis, sclerotic cholangitis, lacrimal gland fibrosis, parathyroid fibrosis leading to hypoparathyroidism. And the thyroid function test usually normal. And we should differentiate between it and thyroid neoplasia, anaplastic thyroid carcinoma. Corticosteroid usually ineffective Surgery may be required if there is a compression, obstruction. Tamoxifen may be of benefit if recent and mild. And actually in previous 2020 year exams, they ask a question about patient presented by fixed hard lump with fine needle aspiration cytology showing a fibrosis. So the diagnosis is radial thyroiditis. Biogenic thyroiditis, this is infection, this is thyroid abscess, so the patient will be presented by tenderness, swelling, and redness, and warmth, and constitutional sign of infection, and treated by antibiotic therapy and incision and drainage if required. Subacute thyroiditis, this is a very important and very common in the exams. This is a post-viral. The patient presented by asthenia, malaise, pain over the thyroid, or pain referred to the lower jaw or ear or occiput, tender thyroid, elevated ESR, low thyroid scan. A patient usually presented in a thyrotoxic stage. Yes, Dr. Nader, I am with you. So, subacute thyroiditis or granulomatous thyroiditis or the quervial thyroiditis or giant cell thyroiditis or post-viral thyroiditis usually presented by very tender thyroid, elevation of the TSR, thyrotoxicose TSH is low with elevation of thyroid hormone, thyroid scan is low. How to treat? Mild cases treated by non-steroidal anti-inflammatory drug. In severe cases, we give glucocorticoid. Prednisolone, 20 to 40 milligram per day are effective. And we can give propranolol if there is a manifestation of thyrotoxicose, tremor, tachycardia, palpitation. The treatment can be withdrawn when normalization of thyroid function, thyroid hormone. Thyroid hormone thyroxine replacement is required if the patient become hypothyroid, because most of cases of thyroiditis is presented by hyperthyroid stage and hypothyroid stage. Carbimazole or propylthyracin is not indicated. So this is a very important issue. Dr. Adina asked about the duration of prednisolone for subacute thyroiditis. Actually, I gave prednisolone for just 1 to 2 weeks, not more. Once the tenderness and the pain is relieved, so we can stop prednisolone. And as you know that once prednisolone not more than 2 weeks, we can stop it abruptly. No need to taper the dose. But if the duration is more than 2 weeks, we should tapering the dose. What are the predictors of permanent hypothyroidism in postpartum thyroiditis? This is actually, I need to search for this question, Dr. Nate. So I will try to find it. So in previous exams, they ask about the question about the quervial thyroiditis, a patient presented by neck pain, fever with elevation of the TSR. What is the treatment? Actually, treatment is non-steroidal anti-inflammatory drug. Another important question from on examination. A 40-year-old female presented with no prior history of thyroid disease, presented by 5-day history of acutely painful left-sided goiter. So what is the differential diagnosis? As I mentioned, the quervial thyroiditis or thyroiditis at least. Also, thyroid nodule can be presented by acutely painful hemorrhage. Clinically, she appeared euthyroid and was apyrexia. Leukocytic count is normal, hemoglobin is normal, and also platelet count is normal. What is the most likely diagnosis? Staphylococcus abscess, hemorrhage, thyroid
Hemorrhage into the test.
carcinoma, DeQuervy, and Hashimoto. What is the most common?
Hemorrhage inside the cyst.
Why not staphylococcal abscess? Why not Hashimoto thyroiditis?
Apyrexia and white
There's no
cell count
fever.
is normal.
Yes.
Yes, so الابيركسيا exclude staphylococcal abscess. Why not DeQuervy thyroiditis?
I expect not all the gland is painful, localized painful, and no viral infection, and also
Yes, actually in the DeQuervy thyroiditis they will mention that tender thyroid, not just painful. Tender. Painful without any palpation of the thyroid. Tenderness in the DeQuervy thyroiditis. Once the patient put his finger in the thyroid gland, it is a very painful. And also, why not Hashimoto thyroiditis? Usually Hashimoto thyroiditis is a non-painful, non-tenderness. So the most common is hemorrhage into the cyst. So don't forget that hemorrhage in the cyst will be presented by acute painful thyroid nodule, and this is a benign condition. Don't forget that the thyroid scan is very important to differentiate between a thyroiditis which is presented by low uptake or toxic adenoma which presented by focal uptake or multi-nodular goiter like this. But if there is a diffuse uptake like this is a Graves' disease. And actually in the previous exam they asked two questions about this thyroid scan. One for a Graves' disease and another one I think toxic adenoma or toxic multinodular goiter. And don't forget that a toxic nodule, the treatment of choice is radioactive iodine ablation. This is the first line treatment in most of our cases, exception of course in lactation, pregnancy, and of course if circumstances is not suitable for radioactive iodine ablation, so the best option is radioactive iodine ablation in most cases. If there is a compression in any thyroid nodule, the best option is surgery. This is a very important issue. Drug-induced thyroiditis, this is a very important topic. Amiodarone, lithium, interferon alpha, and interleukin 2. And actually, in the next session, inshallah, I will cover amiodarone. Amiodarone, in most cases, will cause amiodarone-induced thyrotoxicosis. TSH will be low, but in minor cases, can cause hypothyroidism. Lithium in most cases will cause hypothyroidism, TSH will be elevated, but in little cases will be cause hyperthyroidism. Interferon alpha is another drug and interleukin 2, and inshallah today I will cover some of the drugs that may affect thyroid. When I will repeat ESR and when to repeat TSH, actually ESR, once tenderness relieved, ESR will be normalized. Actually within 2 weeks will be improved. TSH in most cases after 1 to 2 months will repeat TSH. Very, very important topic, which is checkpoint inhibitors. Checkpoint inhibitors. No, Dr. Adil. Dr. Adil asked about a specific goiter size to do fine needle to exclude the thyroid lymphoma. Once a patient presented by Hashimoto thyroiditis and the thyroid enlarged rapidly within a few weeks, you should suspect lymphoma. Checkpoint inhibitor is very important topic since 2018. In each exam there is a question about checkpoint inhibitor, and I will cover this topic actually in the thyroid and also in the pituitary chapter. Checkpoint inhibitor are a new immunomodulatory treatment aiming to suppress overproduction and expression of check protein. Check protein actually like BDL1 present over a tumor cell or T cell. It dumps down the misdirected immune response or keep cancer cell not progressed. Drugs that interfere with checkpoint or inhibit checkpoint like pembrolizumab, which is used for skin cancer and breast cancer, and also can be used in some autoimmune disease like autoimmune hepatitis or autoimmune hemolytic anemia. And another very important drug, which is nivolumab, which is used in the management of renal cell cancer. And actually in our previous exam in 2018, they asked about nivolumab. So immune checkpoint inhibitor, this is a drug that suppress or inhibit BDL1 or BD1, or another one that inhibit CTLA4 like this. So immune checkpoint inhibitor are 3 categories. Drugs that inhibit BDL1 like afliumab, drugs that inhibit BD1 inhibitor like nivolumab, drugs that inhibit CTLA4 like ipilimumab. Actually, drugs name are difficult to spell. So after sometimes you will find it just the names, know the names. So this is from Oxford, the 4th edition. And don't forget that Society of Endocrinology published in 2018 a very important guideline about acute management of endocrine complication of checkpoint inhibitor therapy. And at the same year, we have a question about checkpoint inhibitor in our exam. So I will revise this guideline in the session for thyroid guidelines. Cancer cells hide from the immune system by keeping immune cells from recognizing tumor cells. The checkpoints on T cells act as brakes on their aggressiveness, including programmed DIS1, BD1, and CTLA4. The drugs that block CTLA4, like ipilimumab, this is drugs used for metastatic melanoma. And another drug like nivolumab that inhibit BD1 and its ligands, used for management of non-small cell cancer, renal and bladder cancer, and Hodgkin lymphoma. The most important to know: hypophysitis, thyroid dysfunction, insulin deficient diabetes, type 1 diabetes, and the primary adrenal insufficiency reported from these drugs. Hypophysitis is particularly associated with anti-CTLA4 like ipilimumab, but thyroid dysfunction is particularly associated with nivolumab. Adrenal insufficiency is associated with both drugs, but mostly with nivolumab. In our previous exam, they asked about nivolumab, about immune therapy BD1 inhibitor, and that can cause primary adrenal insufficiency. And in the previous year, they asked a question about ipilimumab, which is a block CTLA4, which can cause hypophysitis. They give a case scenario and mentioned some options like adrenal insufficiency, hypophysitis, thyroid dysfunction, and you will need to choose which one. And actually, I will summarize this in the next slide. But actually, this drug will be associated with transient thyrotoxicosis transient or permanent hypothyroidism, orbitopathy, painless thyroiditis, and rare thyroiditis too. Incidence is about, for thyroid dysfunction, is about 1 to 6 with ipilimumab or nivolumab. Incidence of hypothyroidism is about 5 to 7%. Time of onset 2 to 4 cycles of therapy. Assess thyroid function and antithyroid antibodies at baseline. Commence monitoring at 1 month. And actually, this slide cover the drugs. So CTLA4 inhibitor like ipilimumab, which is used for management of metastatic melanoma, and the most common endocrinological side effects is hypophysitis. This is a very important one. And for PD-1 inhibitor like nivolumab, which is used for metastatic non-small cell carcinoma and renal cell carcinoma and bladder carcinoma and Hodgkin lymphoma, the most side effects is thyroid dysfunction. And for PD-L1 inhibitor like adalimumab, which is used for management of solid tumors. And actually, this is a very important slide which demonstrates the most common side effects of a checkpoint inhibitor. And please look for this one. The most common, which is presented in most, about 80 to 100% of the patient, is hypophysitis, thyroiditis and hypothyroidism, and adrenal insufficiency. Also, this other side effects like myasthenia gravis, ocular toxicity, dermatitis, pruritus, vitiligo, this is not common side effects. The most common is hypophysitis, thyroiditis, hypothyroidism, and adrenal insufficiency. So, Society of Endocrinology published important guidelines because there are a very important side effects for this. The drugs affect the endocrine glands. And actually, this is from important paper about endocrine toxicity of immune check inhibitors, and they mention that how to screen, how to test, and how to treat immune check inhibitor associated endocrinopathy. I just put this table if anyone want to capture it, because this is a very important actually in the management. And actually, the management of endocrinopathy is the same as management of ordinary endocrinopathy. For example, for hypophysitis, how to treat hypophysitis? By replacement therapy by prednisolone. And central hypothyroidism treated by levothyroxine. And the treatment of hypogonadism by replacement by testosterone or cyclic estrogen and progesterone. So, if we suspect hypophysitis, we need to do ACTH and TSH. And how to treat? By prednisolone for replacement therapy. This is the dosage of methylprednisolone if used. And also for hypothyroidism, central hypothyroidism, we treat by levothyroxine in a dosage of 1.6 microgram per kilogram, the same like hypothyroidism. And don't forget that the PD-1 inhibitor can affect the pancreas, causing what is known as immune checkpoint inhibitor associated diabetes mellitus, which is type 1 diabetes, which is treated by insulin, basal bolus insulin. So, a thyroid side effect can be presented by thyrotoxicosis, in which TSH will be low with elevation of the T4, and we should retesting every 4 to 6 weeks. And we need to treat by supportive management, with or without beta blocker. And if the symptoms persist for more than 6 weeks, we should evaluate for other causes. And hypothyroidism should be treated by levothyroxine if TSH is more than 10. And this is primary thyroid disorder. But in the case of central hypothyroidism, we should treat by levothyroxine if T4 is low 3 to 4 is low by the dosage of 1.6 microgram per kilogram as a starting dose. And don't forget that in central hypothyroidism, we should follow up our patient by 3 to 4 mod PSH. Another very important item in the Oxford 4th edition is immune reconstitution therapy. This is the drugs that used in the management of multiple sclerosis, alemtuzumab. Each one ended by mab. And another drug which is used for treatment of HIV, highly active antiretroviral therapy. And another drug in patient used in the undergoing bone marrow hematopoietic stem cell transplantation. Thyroid dysfunction is common in these drugs when we use this drug. So European Thyroid Association in 2019 published a very important guideline about the management of thyroid dysfunction following immune reconstitution therapy. So we have two very important guidelines. Actually, I will summarize these two guidelines in a session of yes, Dr. Najah. Dr. Najah need 5 minutes, just 5 minutes, and we have a break for 15 minutes, Dr. Najah. After this 5 minutes. Actually, in Egypt, we start after Salat al-Asr. Okay. So in both alemtuzumab induced thyroid dysfunction and HIV patient, the commonest disorder is Graves' disease, followed by hypothyroidism, then thyroiditis, then Graves' orbitopathy, which is a very rare. Hypothyroidism is a commoner than Graves' disease, both bone marrow hematopoietic stem cell transplantation. So if we suspect Graves' disease, we should do TSH receptor antibody, and if it is thyrotoxic patient, so this is a stimulating antibody, which is a positive in about 70% of a patient with hypothyroidism as a blocking antibody. Both immune reconstitution and therapy, thyroid dysfunction might follow a typical fluctuation course. In this situation, we show the clinical symptom can take up to 3 months to develop following biochemical thyroid dysfunction. And as a result, routine monitoring of thyroid dysfunction is mandatory. And actually, I will show this guideline actually because this is a very important guideline. I will show this this one, because in the guidelines they mention that how to follow the patient by this table, actually this one, how to follow up. For the first 4 years, we should do thyroid function test assessment 4 times per year, every 3 months after treatment by alemtuzumab. And after 4 years, we should do TSH if there is a thyroid symptom. So for 4 years, we should do TSH every 3 months after the treatment. If Graves' disease is confirmed, we should commence trial of antithyroid drug carbimazole for 3 months, and we should give levothyroxine if overt hypothyroidism or subclinical hypothyroidism persists more than 3 months and or with symptoms. Actually, in the guidelines, they mention this very important table algorithm, how to manage if there is a hyperthyroidism or thyrotoxicosis, and another one if there is a hypothyroidism. And actually, this table I will cover in a separate session about the guidelines. I will start inshallah hypothyroidism. And hypothyroidism is very important topic actually in clinical practice and the exam. Don't conflict about myxedema. Myxedema is hypothyroidism, but pretibial myxedema is a pathognomic feature of Graves' disease. So myxedema is a severe hypothyroidism. The incidence of hypothyroidism is increased in the area of high iodine intake. Elevated of the TSH is associated with dyslipidemia, higher serum lipid concentration, and once the patient is treated by levothyroxine, dyslipidemia is improved. And this is actually the typical feature of patient presented with hypothyroidism. And also, if we focus in this image, the outer third of the eyebrow and the skin, dry skin, and the eye buffness, and the picture, we see a lot of our patient like this, and you diagnose the hypothyroidism once you see the patient. But don't start levothyroxine except after biochemical diagnosis of hypothyroidism. This is a very important, because in some cases, especially in the elderly patient, you see a typical picture of hypothyroidism, and when you do thyroid function test, you will find it is a hyperthyroidism and a vice versa. Clinically, the patient may be, this is an insidious non-specific onset. Usually the patient presented by fatigue, lethargy, constipation, cold intolerance, muscle stiffness, cramps, carpal tunnel syndrome, menorrhagia, or oligo or amenorrhea. Slowing of intellectual and motor activity, decreased appetite and weight gain. Dry skin, hair loss, deep hoarse voice, decreased visual acuity, obstructive sleep apnea. And this is a severe form of hypothyroidism, which is myxedema, dull expressionless face, cool skin and feels rough and doughty, enlarged heart, dilatation and pericardial effusion, and I will show a picture of it. Megacolon, cerebral ataxia, prolonged relaxation phase of the deep tendon reflexes, and also may be presented by peripheral neuropathy, encephalopathy, hyperlipidemia, hypercarotenemia, and psychiatric symptom. And don't forget hyponatremia. Hypothyroidism is manifested by hyponatremia. And this is actually due to the impaired water excretion and disordered regulation of the vasopressin secretion. Is my voice clear now?
Yes.
Okay.
Yes.
And this just summarize the common manifestation of hyperthyroidism versus hypothyroidism. For example, hypothyroidism presented by pretibial edema, but the patient of hyperthyroidism may be presented by exophthalmos or ophthalmoplegia. Husky voice or goiter may be presented in the post condition, bradycardia here, tachycardia, menorrhagia here, oligomenorrhea in the hyperthyroidism, constipation or irregular stool, but in the case of hyperthyroidism, increase the frequency of stool, not a diarrhea. Actually, not a diarrhea. It is increased the frequency of stool. And actually, this is a patient presented by a severe hypothyroidism. And once treated by only levothyroxine, after a few months, the X-ray chest returned to be normal. So here, the cardiothoracic ratio is increased, cardiomegaly and pericardial effusion. But once treated by levothyroxine, the X-ray cardiac size normalized after a few months. This is another case scenario. A 32-year-old woman decided to go on strict vegan diet for a year. She has recently returned from a world tour and visited sub-Saharan countries. This is an area manifested by low iodine prevalence, and went on an expedition in the Himalayas. She presented with a diffuse smooth goiter. Her blood shows euthyroid status and negative antithyroid antibody. What is the next investigation to establish the likely diagnosis? The patient presented by diffuse smooth goiter with normal thyroid function test, with normal anti-TBO.
Urinary iodine excretion or
Why
ultrasound.
urinary? To exclude the iodine deficiency. So in this situation we should exclude the iodine deficiency, diffuse thyroid enlargement due to the iodine deficiency. So we need to do urinary iodine excretion ratio. If it is less than 50 microgram per liter, this is a diagnostic for iodine deficiency. Dr. Hanadi asked about how to start it. Dr. Hanadi, how to start treatment of hypothyroidism, 1.6 microgram per kilogram, or start by a small dose like 50 microgram per day and upgrade the dose within 2 weeks. Actually, I will cover the treatment later, inshallah, in this presentation. Doctor, how to keep TSH within the normal range by if the patient hypothyroid, so we should give levothyroxine. I will cover treatment, all details of treatment later, inshallah. The classification of hypothyroidism, we should differentiate between non-goitrous and goitrous hypothyroidism and primary hypothyroidism. And the primary hypothyroidism means the TSH must be elevated. If Lef-34 is normal, this is a subclinical hypothyroidism. If Lef-34 is low, this is overt hypothyroidism. And non-goitrous hypothyroidism, like for example, post-ablative, either radioiodine ablation or surgery, the patient will be presented by non-goitrous hypothyroidism, or due to the congenital development defect in the neonates, or atrophic thyroiditis, which is end-stage thyroid disease, or post-radiation, for example, for lymphoma, will lead to non-goitrous hypothyroidism. Goitrous, the most common cause of goitrous hypothyroidism is Hashimoto thyroiditis, and also iodine deficiency will lead to goitrous hypothyroidism. And also goitrous may be transient hypothyroidism for most of the case of thyroiditis, like Puervian thyroiditis. Drug-induced thyroiditis, drug-induced hypothyroidism like amiodarone, for example, will lead to elevation of the TSH. Drug-induced hyperthyroidism will lead to decreased TSH. Hemochromatosis and heritable biosynthetic defect and maternal transmitted disorders can cause goitrous hypothyroidism. Another very important cause of hypothyroidism is central hypothyroidism due to the pituitary or hypothalamic lesion. And actually, European Thyroid Association published a very important guidelines in 2018 about management, diagnosis, and management of central hypothyroidism, either due to the pituitary disorder like panhypopituitarism or isolated TSH deficiency, or some drugs like bixarotene, or due to the hypothalamic disorder like neoplasia, or infiltrative disorder like sarcoidosis, or congenital defect or infection like encephalitis. These two conditions, pituitary and hypothalamic, lead to central hypothyroidism. And actually, I gave a previous presentation about the central hypothyroidism in ETA guidelines in a previous Thyroalex, I think 10. And I will put the link for this presentation after finishing this session, inshallah. And also don't forget that some patients may be presented by a picture like hypothyroidism, for example, following the withdrawal of suppressive thyroid therapy, or subacute thyroiditis and the chronic thyroiditis may be presented by a picture of elevation of the TSH with low Lef-34, which is typical like primary overt hypothyroidism. Some of pitfalls with a thyroid function test, we should put it in our mind in a non-thyroidal illness. The TSH will be low in hospitalized patient, in severely ill patient. The TSH will be low in the patient receiving dopamine or steroid. And after recovery of the acute illness, the TSH will be elevated. The TSH may be low in the first trimester of pregnancy due to the HCG is mimic TSH action. TSH inhibited by subcutaneous octreotide, as I mentioned previously, octreotide will inhibit the pituitary gland, will inhibit TSH. Anorexia nervosa is associated with low TSH and free T4. Don't forget this. Anorexia nervosa will be manifested by low TSH and free T4. And الهيتروفيل antibody including rheumatoid factor may falsely elevate TSH, and this is say interference. And don't forget that adrenal insufficiency may be associated with a raised TSH, mild elevation of the TSH. And in this situation, if you give thyroxine, the patient acutely presented by crisis. So don't forget to check hypothalamic pituitary adrenal axis before treatment of a hypothyroidism, specifically if the patient is presented by manifestation of hypoadrenalism. Subclinical hypothyroidism, and as I mentioned a lot of time today, there is a very important guidelines published by European Thyroid Association, but it is 2013 for the management of subclinical hypothyroidism. Subclinical hypothyroidism means what? Elevation of the TSH with normal free thyroid hormone. Don't forget that in hypothyroidism, we usually depend on T4, not T3. So assessment of T3 in hypothyroidism has no value. A treatment of subclinical hypothyroidism is indicated not in all cases. If you diagnose subclinical hypothyroidism, when to treat is very important in a clinical practice and in exam. If there is a history of radioiodine treatment, we should treat subclinical hypothyroidism. If there is a positive anti-TPO or anti-TG, we should treat subclinical hypothyroidism. If the patient is pregnant or symptomatic, we should treat. But actually, a diagnosis of subclinical hypothyroidism means 2 samples should be taken 2 to 3 months apart to distinguish from non-thyroidal illness. The same for subclinical hyperthyroidism. We should do a repeat sample within 2 to 3 months to label the patient is persistent subclinical hyperthyroidism. So, and don't forget that the reference range of the TSH is rises with the age and different TSH reference range during pregnancy. And actually, treatment of subclinical hypothyroidism has a sum of controversy. Some of societies recommend not to treat subclinical hypothyroidism except in little situation, and another one recommended treatment if anti-TPO is positive, if symptoms, if pregnant, if another autoimmune thyroid autoimmune disorders, and so on. And in all recommendation, it is recommended that if a treatment is not given, we should follow annual thyroid function test is very important. So, some authorities suggest treatment if TSH is more than 10. And don't forget that with the elderly, treatment must be less than non-elderly personnel. So, ETA guidelines recommend treatment according to the age. This is the first one. If the age is more than 65, don't treat except if TSH is more than 10 and symptomatic. If the age is more than 65 to 70 years of age. For the elderly, don't treat except TSH is more than 10 plus symptoms of hypothyroidism. And this is a trial. If the symptoms is not improved after 3 months, please stop thyroxine. For the young personnel, treatment is different. If TSH is more than 10, we should treat. If TSH is less than 10, if there is a symptom, we should trial of treatment. But actually, if pregnant or lactating or another autoimmune disorder or anti-TB was positive in this situation, we can treat. If a patient presented with recurrent miscarriage, we should bring TSH to be less than 2.5. And actually, in the fourth edition of the Oxford Handbook, they mention that we should treat if TSH is more than 4, not more than 2.5. So, a reference range during the first trimester is different according to the latest guideline. The latest guidelines mention that TSH can be up to 4 during the pregnancy. But actually, I will discuss it later according to the presence of TBO. If TBO is positive, I will treat if TSH more than 2.5. If TSH negative, I will treat if TSH is more than 4. This is very important update in the latest guidelines of American Thyroid Association actually. So don't forget that the aim of TSH preconception is normalization of the TSH to be in the lower half of the reference rate. It is better to be less than 2.5. Dr. Hanadi mentions that the new guideline not to treat even during the pregnancy with positive anti-TBO. I will cover it actually, Dr. Hanadi. I will cover this point after a few slides actually, because this is a very important and I will summarize it in the very important algorithm. So don't forget that in some of previous exam, they mentioned that hypothyroid female planning pregnancy, what is the target of the TSH is less than 2.5. Or keep TSH in the reference range preconception. Which one, Dr. Fathi? I will cover subclinical hypothyroidism during the pregnancy after a few slides actually, because it is very important. So subclinical hypothyroidism, when to treat, this is for exam and for clinical practice. Okay. Yes, actually, in any patient presented by recurrent miscarriage, we can treat even if the TSH is normal. If the anti-TBO is positive and the TSH between 2.5 and 4, in this situation, we consider treatment. If the TSH is less than 2.5 and recurrent miscarriage, some authors recommend treatment by small dose of levothyroxine. But actually, the very important study published in the New England Journal of Medicine tablet study mentions that if TSH is less than 2.5 and the anti-TBO is positive, no benefits of treatment. So I think in the recent guidelines, within a few next few years, I think if TSH is less than 2.5, no rule for levothyroxine. So how to treat subclinical hypothyroidism? This is for exam, this is for a clinical practice. If TSH is more than 10, we should give levothyroxine. If TSH is mildly elevated between 4 to 10, so this is a subclinical with, of course, normalization, normal 3 to 4. TBO is positive, we should treat. We should give a trial of treatment. And if no treatment, if the anti-TBO is positive, we should annually check of the TSH yearly. If the anti-TBO is negative, we should check TSH every 3 to 5 years. If there is a symptoms and the TSH is less than 10, we consider treatment, a trial of treatment for 3 months, therapeutic trial of levothyroxine. Of course, TPO is positive and subclinical hypothyroidism. The progression to overt hypothyroidism is about 5% per year. So we should annual doing serum TSH. If the anti-TPO is negative, we consider a 3-year serum TSH assessment. The exception of this is in neonate and children and pregnancy, or any female trying to conceive. In this situation, if the TSH is more than 4, in a previous recommendation, if the TSH is more than 2.5, we should always be treated by levothyroxine. Levothyroxine treatment for those with a serum TSH 4 to 10 may just find in patient less than 65 and in those older subject and in patient with cardiac disorders, heart failure on the echocardiogram. I will cover this actually in this situation. Because in the guidelines, I will cover this guideline, subclinical, this guideline, subclinical hypothyroidism, ETA guidelines. They mention that how to manage according to this algorithm. Hello, Dr. Wael. Wael Sidrak. Nice to meet you, Dr. Wael. So this is a recommendation by ETA guidelines published in 2013. How to manage a patient with persistent subclinical hypothyroidism in a non-pregnant adults. If the age is more than 70, in the previous recommendation 65, so it is recommended to write it 65 to 70 age. If the serum TSH less than 10, observe and repeat thyroid function test within 6 months. If it TSH is more than 10, consider treatment only if a clear symptom of hypothyroidism or high vascular risk. In this situation only, we should consider treatment, but actually we should start by a small dose of levothyroxine. In another situation, if the age is less than 70 years of age, if it TSH is more than 10, we should treat by levothyroxine. If it TSH is less than 10, we should go to, if there is a symptoms, we give a trial of levothyroxine for 3 months. If no symptoms, we should observe and repeat thyroid function test in 6 months. This is actually the guidelines, and they did not mention anti-TPO in this recommendation. But actually for the exam, if an anti-TPO is positive, we should consider treatment. If another autoimmune disease, we consider treatment. And this is a very important topic. So I will go to this case scenario. A patient present a 55-year-old female who received radioiodine over 5 years ago, presented for annual thyroid function assessment. She takes no medication. The most important is TSH is elevated with normal free thyroxine, free T4. So this is a case of subclinical hypothyroidism. Total cholesterol is elevated, plasma triglyceride elevated. What is the most appropriate treatment for this patient, dyslipidemia? Here he asked about management of dyslipidemia.
Thyroxine.
Thyroxine, also 5.
Levothyroxine.
Yes. So actually he asked about the management of dyslipidemia, but the treatment should go to thyroxine. Because as I mentioned previously, dyslipidemia usually presented in a patient presented with hypothyroidism, and treatment of hypothyroidism can, in most cases, can resolve dyslipidemia. So how to treat hypothyroidism is a very important topic, and actually this is a very important topic in my presentation today in the clinical practice and actually in the exam. And I will cover combination therapy levothyroxine with T3. So synthetic levothyroxine or thyroxine remains the treatment of choice. Why? Because the half-life of levothyroxine is long. It is about 6 to 7 days. Don't forget this half-life, because in the exam they usually ask about the half-life. In our exam they ask about the half-life of growth hormone and the iodine 131. And in other situations they ask about the half-life of I think parathyroid hormone and so on. So try to collect the half-life of drugs and hormones, and at least the most common hormones and drugs, because this is maybe a question in the exam. For replacement dose in the management of overt hypothyroidism, usually between 1.6 to 1.8 microgram per kilogram per day. So don't forget this number, 1.6 microgram per kilogram per day. To avoid iatrogenic subclinical disease, fasting ingestion of levothyroxine is best either in the morning or evening, and I will cover this issue later. The timing of levothyroxine is very important, but I want to know, all of you know the dosage of replacement therapy is 1.6 microgram per kilogram per day. In the young patient, start levothyroxine at 50 to 100 microgram and increase the dose every 6 to 8 weeks according to the TSH, to the full replacement dose. But in the elderly, we should start by a small dose. I will cover it. Yes?
You mean the start by 50 and 100 microgram and increase
100
gradually,
and increase the dose. This is one option, Dr. Anijah.
1.6 to 1.8.
Actually, I start and I will cover this later, Dr. Anijah. But actually, in my clinical practice, I start by full replacement dose. Put my patient over the meter and calculate the dose, full replacement dose. But there are two cases you need to start by small dose and increase it gradually. In the elderly and in a patient with cardiac disease, we should start by small dose. In another situation, there are two options. We can start by small dose and increase it every some weeks, and another option to start full replacement dose, and this is the preferred one. Actually, I will cover it immediately. Actually, weight. I mean the weight, Dr. Shavan, not meter. Weight. By weight. And just calculate the weight of the patient and multiply it in 1.6 microgram. If a patient is hypothyroid and marginally increased prolactin and a bit reduced testosterone, how long do we keep him on levothyroxine before other line of treatment like testosterone or cabergoline? According to hypothyroidism, actually primary hypothyroidism will lead to increase the prolactin by small numbers. So if the patient after correction and normalization of the TSH is still prolactin is elevated with low testosterone, in this situation we should search for hypogonadism. Is it non-function pituitary adenoma that cause hyperprolactinemia and causing hypogonadism, or another cause of hypogonadism? But once in normalization of the TSH occurs within, for example, 2 months, actually hypogonadism caused by hyperprolactinemia that is caused by primary hypothyroidism should be resolved. So in a young patient, start levothyroxine at 50 to 100 microgram. In the elderly with a history of ischemic heart disease, we should start by a small dose at 25 to 50 microgram. That increased by 25 microgram every 1 month until normal metabolic state and normalization of the TSH. The optimal dose is determined by clinical criteria. the objective of our treatment is normalization of the TSH and improve symptoms, but the main target is normalization of the TSH. The TSH should be checked only 6 weeks, 6 to 8 weeks after any dosage change, because the half-life of levothyroxine is 6 to 7 days. Once stabilized, the TSH should be checked annually. The muscle problem may take up to 6 months to fully recovery. The skin manifestation usually improved after 3 to 6 months. So dry skin, eye buffness, hair loss don't improve rapidly. And still 5% of hypothyroid patients remain symptomatic in spite of levothyroxine replacement and normalization of the TSH. And for this small percentage of the people, we can consider combination therapy with T4 and T3, but not routinely. So don't forget that 5% of hypothyroid patients remain symptomatic in spite of levothyroxine replacement and normalization of the TSH. Possible cause why those patients still symptomatizing, because this is a chronic disease, maybe due to the associated another autoimmune disease, maybe thyroid autoimmunity per se, may this cause symptoms that is not improved with levothyroxine treatment. For the vast majority of the patient on levothyroxine, a brand or name supplier prescription is not considered necessary. But don't forget that if you start by a specific trade name of levothyroxine, please don't change this trade name. So, for example, in our country, levothyroxine is presented as euthyrox and eltroxin. Don't let the patient receive eltroxin in some months and in another months received euthyrox before, because these two drugs not biochemically equivalent. If you change the form, if you change the trade name, please recheck thyroid function test after 6 weeks. So any change in the dosage or the form of levothyroxine, we need to check thyroid function test. And actually, it is recommended worldwide. The brand or generic of levothyroxine is no superiority on one above the others. But rarely patient may require a specific brand because the patient cannot tolerate generic preparation, because the incipient that is presented in the drug is not the same. So in the Oxford Handbook, they mention this table because the excipient, they mention the excipient in different trade name of levothyroxine. This is not important table, but you should know that the excipient is different from brands. Don't forget that patient with iatrogenic hyperthyroidism who received levothyroxine in a dosage more than he needed can be presented by iatrogenic hyperthyroidism, which increases the risk of arrhythmia and fracture. And in this situation, the treatment of choice is to reduce the dosage of levothyroxine. The combination therapy levothyroxine with T3 does not appear to be superior to levothyroxine monotherapy. So the combination is not recommended in most cases. Clinical trial of combination levothyroxine have not successfully replicated physiological T4, T3 production. And I will cover this later. Don't forget that in the second central hypothyroidism, we should follow our patient by free T4, not TSH. Actually, in primary hypothyroidism, the main target of a treatment is normalization of the TSH. But in the central hypothyroidism, free T4, normalization of a free T4. A dose requirement can increase by 25 to 50% in the pregnancy, and this is very important. Once the female gets pregnant, in a stable dose of levothyroxine, we should increase the dosage by 25 microgram, 25 to 50 microgram any female on replacement therapy when she learns she is pregnant, and this is very important. Dr. Shavan, which one? Increase the dosage or how to follow up the target of central? Yes. In a case of heterogenic, of course, as you know that heterogenic hyperthyroidism, what is the cause of heterogenic hyperthyroidism? The patient received excessive dose of levothyroxine. This will increase the risk of arrhythmia and fracture. How to treat? Decrease the dosage of levothyroxine or stop it if the patient received it heterogenically. So don't forget that in pregnancy, once the patient gets pregnant, we should increase the dosage of levothyroxine by 25 to 50% or 25 to 50 microgram excess dose. Dr. Rasha asked, should we check thyroid function test before increasing the dose? If the patient is pregnant, according to the situation. If thyroid function test will appear immediately or within 1 day, so we can wait until it TSH assessment. If the testing need a lot of time appears after, for example, a few days, we should increase immediately. And actually, all of cases of pregnant female need to increase the dosage of levothyroxine if they already stable in preconception. In subclinical hypothyroidism, how dose be calculated, because 1.6 kilogram will be so much. Actually, I will cover it, Dr. Adil, and actually in most cases of subclinical hypothyroidism, there are two approaches. One approach to start by 1.2 microgram per kilogram per day, and another one according to the magnitude of the TSH. If it TSH more than 10, we can start by 75 microgram. If it TSH is less than 10, we can start by 50 to 75 microgram per day. This is a rough dosage, and I will upload my presentation about subclinical thyroid disorders. So this is a very important slide. Dose requirement can increase by 25 to 50 microgram. And another, the same book, they mention that increase the dose by 25 to 50% in a pregnancy due to the increase in the TPG. Data have shown that mild maternal hypothyroidism in the first trimester is associated with a slight impaired cognitive function in the offspring. So each female, it is routinely recommended to increase the levothyroxine dose by 25 microgram in any female or replacement therapy when she learns she is pregnant. And actually, in previous exams, they asked a question about hypothyroid planning pregnancy, keeping TSH in the reference range less than 2.5. And here in this exam, they mentioned the question about the pregnant with a previous abortion, and the TSH is 5. Of course, we should treat by levothyroxine. And in 21 exams, they give a question, one patient with hypothyroid in 100 microgram levothyroxine, now pregnant, and the TSH is normal, 1.2. What is the treatment? Actually, even controlled, you should increase the dose by 30% or 25%. So in this situation, we should increase the dosage by 25%, even if the TSH is normal. But if the TSH is lower normal, for example, is less than 0.5, in this situation, I can postpone this increasing the dose. But if TSH is 1 or 1 and more, even if less than 2.5, I will increase the dosage by 25%. And actually, in our previous exams, they mentioned the question like this, but L3T4 is lower than normal. And they give to increase the dosage to 25 or 50 microgram. And as L3T4 is low, in this situation, I should increase the dosage by 50 microgram per day. So this is a very important algorithm how to manage subclinical hypothyroidism during the pregnancy according to the latest guidelines published by the American Thyroid Association, and actually this is a very important and practical algorithm. How to manage subclinical hypothyroidism if TSH is less than 2.5? In this situation, no further workup. If TSH between 0.1 to 2.5, this is a normal reference range during the first trimester. In this situation, no further workup. If TSH is more than 10, we should treat by levothyroxine. This is for subclinical hypothyroidism during the pregnancy. If TSH between 2.5 to 10, in this situation, we should go to doing thyroid TBO antibody. TBO antibody. If it is negative, in this situation, if it TSH between 2.5 to 4, in this situation, we should not treat this patient. If it TSH between 4 to 10, we should consider treatment. Not a very strong evidence to treat, but treatment should be considered if it TSH between 4 and 10 with negative anti-TBO. If the anti-TBO is positive, in this situation, TSH between 2.5 to 4, in this situation, we consider treatment. Look for this. This is because the TBO is positive, we consider treatment if it TSH between 2.5 and 4, but in this situation, because the TBO is negative, we should not treat. And if it TSH between 4 and 10, we should treat. So the main difference here, according to the anti-TBO, if TBO is positive, we consider treatment if TSH is more than 2.5. But if TBO is negative, we consider treatment if TSH is more than 4. This is the main difference. If the TSH is below 0.1, should we decrease the dose according to the clinical scenario, Dr. Akesi? For example, if the patient receiving thyroxine as a suppressive therapy for differential thyroid carcinoma, leave the dose as it is. But if the patient receive levothyroxine as a replacement therapy, in this situation, this is iatrogenic thyrotoxicose, and I will decrease the dosage, especially if free thyroid hormone is elevated more than normal. But if the free T4 is normal or low normal, in this situation, I will not decrease the dosage. If TBO is positive and the TSH is less than 2.5, most of authorities don't recommend treatment by levothyroxine, Dr. Chavez, in this situation. If TSH is less than 2.5, no treatment is required, even if the anti-TBO is positive, because there is a very important paper published in the New England. I will mention it actually here. New England Journal of Medicine, I think, tablet trial, levothyroxine anti-TBO with pregnancy. This is a trial. I will show this is no, not this. This is one. In conclusion, a tablet trial which show no effect of levothyroxine in live birth rate in euthyroid TBO positive women. This raises important question regarding the pathophysiology of miscarriage, and I think this is published in the New England, I think. So this is a tablet trial, not in New England. This is a tablet trial mentions that no role for levothyroxine, no benefits received. when treating if TSH is less than 2.5. And I think I will show levothyroxine in anti-TB pregnant woman. This is one. This is a levothyroxine in the woman with thyroid peroxidase antibody before conception. This is published in the New England Journal of Medicine, and this is April 2019. And I will go to the conclusion. The use of levothyroxine in each thyroid woman with thyroid peroxidase antibody did not result in a higher rate of live births than placebo. And actually, according to this trial, no recommendation if the anti-TB is positive with TSH is less than 2.5. So this algorithm is very important practically and in exam. And this is a question in our previous exam. They mentioned that a female patient presented in the second trimester on levothyroxine. TSH is elevated with Lefriti-4 is low. In this situation, we should increase the levothyroxine dose by 50 microgram. So the correct one is increase thyroxine to 150 microgram per day. The starting dose of levothyroxine, and this is according to the latest guidelines published by the NICE guidelines in 2019. And actually, I will cover this guideline in the session for the guideline. And this actually is the answer of the question of Dr. Najah. Some evidence showed that a high starting dose of levothyroxine produced more rapid improvement in quality of life than lower starting dose following by titration. So here they recommend that starting by a full replacement dose 1.6 microgram per kilogram body weight is better than a low titration dose. But in a patient over 65 or cardiovascular disease, we should start by a small dose. The committee agreed to recommend a lower starting dose with a titration for people over 65 and of course for cardiac disease. And this table is very important. Drugs that and conditions that alter levothyroxine requirement, and this is from the William textbook of endocrinology, the latest edition. The drugs that interfere with levothyroxine absorption, don't forget cholestyramine, sacralfate, ammonium hydroxide, calcium carbonate, and ferrous sulfate. And don't forget orlistate. This drug interfere with levothyroxine absorption. Sacralfate, ammonium hydroxide, calcium carbonate, ferrous sulfate. And also another drug that increase the cytochrome P450 enzyme, rivampicin, carbamazepine, estrogen phenytoin, sertraline, and to some extent statin. And in this situation, we should increase the dosage of levothyroxine in most of cases. And also there are some drugs that block the conversion of T4 to T3, like amiodarone, and some drugs that block the adenase synthesis, the selenium deficiency, the cirrhosis. And we need to decrease the levothyroxine requirement for the elderly and if the patient in androgen therapy, female. And so there is some conditions that we need to increase the levothyroxine dose requirement, like pregnancy, and don't forget some of gastrointestinal disorder, like mucosal disease of small bowel, SPRO, after jejunal bypass and small bowel resection, or diabetic diarrhea, or atrophic gastritis, or a patient with H. pylori infection. In this situation, we should increase the dosage of levothyroxine. So as absorption is impaired, so we need to increase the dosage of levothyroxine. Don't forget, during pregnancy, we need to increase the dosage by 25 to 50 microgram or percent. In a gastrointestinal disorders will affect the absorption, so we need to increase the dosage of levothyroxine. Some drugs that can interfere with levothyroxine, so we should at least 4 hours from this drug, we should receive levothyroxine before this drug by at least 4 hours. الكالسيوم، الفيرس سلفيت، السكرالفيت، الكوليسترامين، aluminum hydroxide, and some drugs that can increase the excretion of levothyroxine. So this is a very important. Okay, this is a question. Which of the following is the most useful test for assessing the appropriateness of the thyroid hormone replacement in a primary hypothyroidism?
TSH.
Yes, TSH is the only test to check in a case of primary hypothyroidism. 3T4 in a case of central hypothyroidism. TSH and 3T4 if you need to check the compliance. If you need to check thyroid status in infant and you need to do TSH and 3T4. But actually in the adults, the follow-up just doing TSH. This is some controversial in the management of hypothyroidism. The milk injection just apart from levothyroxine by 1 hour. So if you, and I will cover it later on, levothyroxine need to be taken in empty stomach before the first meal, before the breakfast by 1 hour. But if the patient need a calcium supplementation or iron, you need to take this medication 4 hours apart from levothyroxine. The milk, I know the milk contains a calcium, but this is a natural calcium, no need to be apart more than 1 hour. Another time that we can take levothyroxine at bedtime, but in this situation, the patient should be not taking a food at least 3 hours before the levothyroxine intake. So this is some hints about the management. Normal TSH level exclude the primary thyroid disorder. Primary hypothyroidism, TSH must be elevated. So we should diagnose the primary hypothyroidism according to the TSH. Even if the patient is manifested by manifestation of hypothyroidism with normal TSH, in this situation, primary hypothyroidism is excluded by 100%. If you want to check central hypothyroidism, we should do 3T4 and TSH. So primary hypothyroidism should not be diagnosed on the basis of the symptom alone. And this is in the UK, national audit data suggests that over 10% of those who began on levothyroxine in primary care initially had a normal TSH. So this is the UK. If we do this survey in our countries, I think it is more and more than 50%. Because we see in our clinical practice a lot of physicians doing thyroid hormone only without TSH. Normal TSH exclude the primary thyroid disorder by 100%. What about the T3? I will cover, Dr. Hana, this T3 and how to give it in pregnant female and so on. I will cover it within a few slides, because this is a very important topic. Dr. Sana, patient who are in corticosteroid as it suppress TSH, so how to adjust thyroxine dose depending on the TSH level. Actually, corticosteroid decrease the level of the TSH, not suppress the TSH, just decrease the TSH, mildly low TSH. And actually, physiological dose of corticosteroid does not suppress the TSH. The physiological dose of corticosteroid does not decrease the TSH. The high dose of corticosteroids that is given in the intensive care unit or a patient with some sort of indication of very high dose of corticosteroids, this is high dose will decrease the TSH a little. a significant minority of patients on levothyroxine have ongoing symptoms despite normal TSH, thyroid function test. This is a non-specific symptom like lethargy, brain fog, difficulty in weight management, occurs in up to 5 to 10% of the treated hypothyroidism, and explanation mainly due to the chronic disease or autoimmunity, as I mentioned previously, or another autoimmune disease like vitamin B12 deficiency or cortisol deficiency or iron deficiency anemia or chronic fatigue syndrome or hypercalcemia or liver disease or cardiac disease. So search for another cause of these non-specific symptoms. The measurement of serum T3 is of no value in hypothyroidism. Has no value either in diagnosis or in the follow-up. So the monitoring mainly TSH and the free T4 in central hypothyroidism. The genetic characterization of type 2 dehydrogenase gene polyphorism is not indicated. So if you suspect type 2 dehydrogenase enzyme defect, don't do polymorphism gene analysis. Genetic testing is not recommended as a guide to selecting a therapy. In levothyroxine, this is a combination therapy. This is a very important topic, levothyroxine and liothyronine combination therapy. And actually, I would like to mention that the European Thyroid Association published in a 2012 guideline about this combination therapy in the management of hypothyroidism. And I will cover this guideline in the following few slides. So don't forget that T4 to T3 ratio in a human is 14 to 1, 15 to 1, 20 to 1. This ratio is very important because in each exam they give a question about this ratio. Don't forget this. But actually in a porcine thyroid extracts were far from the physiological. In a big thyroid products, T4 to T3 ratio is 4 to 1. And it is a recommendation about the combination therapy, no added benefit of combination levothyroxine with liothyronine over levothyroxine therapy alone in a term of quality of life, mood, psychometric measures. So the combination therapy is not recommended routinely. And actually, levothyroxine is available as L-troxin or euthyrox. Liothyronine is available, the original is cytomel in a different concentration, 5 microgram, 25 microgram, and 50 microgram. And thyroxine is available in a different trade names. And also, both drugs, levothyroxine, liothyronine, is already available in one tablet in different concentration. For example, this is by Merck, Novocerel is presented in 75 concentration. This is mean 75 microgram T4 and 15 microgram T3. And also available in a different concentration like Novocerel 100. This is means 100 microgram levothyroxine and 20 microgram liothyronine. Different concentration with different ratios, not the same ratio. So this is very important if you decide to write this drug. So the all recommendation, the all guidelines recommend this drug to be prescribed by specialized referrer who have a well trained upon this drug. Combination therapy is not recommended for thyroid cancer, for pregnancy, for a patient over age of 60 or any age with known heart disease. This is not a recommendation by the guideline. So, a combination therapy is not recommended during pregnancy, for the elderly, for a patient with heart disease, for a thyroid cancer. It is suggested to start a combination therapy in a levothyroxine lioshyronine dose ratio between 10 to 1 and 20 to 1. So if we give levothyroxine 100, we should give lioshyronine between 10 to 20.
10 to 5.
10 to 5, 10 to 5, yes, 10 to 5. So I stopped to revise this. Okay. By the weight, levothyroxine given once daily, lioshyronine is given in divided doses. Fixed amount of levothyroxine, this is the most practical dosage to be used. Levothyroxine 50 microgram is replaced by 10 microgram lioshyronine. So in this situation, the dosage is 10 to 1. 10 to كام دي؟ 10 to 5.
5 to 1. 5 to 1 or 10 to 2.
This is a 5 to 1. And this is not the recommendation by the guideline. And we should reassess. No specific scoring system exists for reassessment at 6 months. And actually, this is a question in the previous. I will cover the combination and the dosage according to the guidelines later on, actually, after a few slides. And this is actually the question in the previous exam, 2022. A pregnant female with hypothyroidism on combination therapy T4 and T3. T4, the dosage 75. T3 is 15, like this one, Levothyroxine 75. It contains 75 levothyroxine and 15 microgram lioshyronine. And the T3 dose was increased in the 9th week from 10 to 15, and now she is 14 weeks with T6 is low, T3 and T4 a bit high. How to manage? Not change, stop T3, increase dosage of the T3, continue T4 and the T3 combination.
Before the stop T3.
Stop.
Actually, I will choose stop T3. Why to stop T3? Because all recommendation does not recommend lioshyronine during the pregnancy. But according to the case scenario, actually, if we see the numbers, I will choose a different option. Maybe I choose a different option. Yes.
في سؤال جه في الامتحان برضه the physiological T4 to T3 in the exam.
Actually, it is 15 to 1.
15 to 1?
Yes, and actually I cover this a lot of time, and I cover this actually even in this book. I will mention this. This is from the Oxford 4th edition, compared with a ratio of 14 to 1 in a human thyroid. This is a normal ratio. It is actually it is between 13 to 1 to 90 to 1. So 15 to 1 is the most accurate answer. And actually, I put this and the explanation for this in second session, thyrotoxicosis session. So this is actually a British national formula. This is the latest edition of BNF, and I extract lioshyronine sodium. The initial dose is 10 in the management of hypothyroidism. 10 to 20 microgram daily should be increased to 60 microgram into 2 to 3 divided doses. And actually 20 to 25 microgram is equivalent to 100 microgram of levothyroxine, which is equivalent to 100 to 20. So it is 1 to 5 in this situation. And don't forget that lioshyronine does not cross the placenta in a significant amount, like T4. And the dose adjustment in lioshyronine requirement may increase during the pregnancy, but it is not approved during the pregnancy actually. And this is from the American guidelines. In American guidelines, the recommended treatment of maternal hypothyroidism is administration of oral levothyroxine. Other thyroid preparations such as T3 or desiccated thyroid should not be used in pregnancy. And actually also in the guidelines they mention that the ratio of T4 to T3 is 14:1. This is a ratio of secretion of a human thyroid gland. T4 to T3, it is 14:1. And I extract some recommendation from the guideline published by the ETA about the combination therapy. And actually, I will cover this recommendation. I will continue the presentation in the next Friday because we just in the mid of this presentation. So the first recommendation, it is suggested that levothyroxine plus liothyronine combination therapy might be considered as an experimental approach and can be used if there is a persistent complaints despite serum TSH value within the reference range, supporting to deal with the chronic nature. A T4 combination therapy T4 and T3 is not recommended during pregnancy and also in a cardiac arrhythmia. And also it is recommended to discontinue this combination if no improvement in the symptoms within 3 months of treatment. And if we use this combination therapy, we should start by a dose ratio of 13:1 to 20:1 by weight. And it is ideal to give levothyroxine once daily, and give liothyronine should be divided if possible in 2 doses, one before breakfast and the largest one before sleeping. And this is not done if we use a combined bed. So the guideline it is recommended to use a separate levothyroxine and liothyronine tablet in a 2-tablet formulation, not in a combination therapy, because it is available in a combination in a different concentration. For example, this drug Thyroid by Sanofi, it is presented 100 microgram T4 and 10 microgram T3 in a ratio of 10:1, which is not a physiological ratio. And this one is presented in 120, which is 1:5, 5:1. And this is another one in a different concentration. So the guideline recommend to give 2 drugs in a separate pill. This is a very important, and this is a very important in solving any question. It is recommended that LT4 and T3 combination therapy should be monitored by thyroid function test in a blood sample withdrawn before morning medication has been taken, aiming at normalization of the TSH, free T4, free T3, and the free T4 T3 ratio. And the most important dose adjustment, how to adjust the dose, it is suggested that the dose of just one of the component is changed, preferably liothyronine. So for non-pregnant female, if you give a T4 and T3, you should follow by TSH, free T4 and T3 and the ratio. And if you need to adjust the dosage, you need to adjust only T3, not T4. And actually in the guidelines, they mention that to take thyroid function test and change the dose of just one of the component. If the serum free T3 is too low, in this situation, you need to increase the dosage of T3. If the patient on cytomel 5 microgram twice a daily, we can go to 25 microgram once or twice a day, or double the dose. But what is not, I can not understand, they mentioned that if free T4 is too high, increase of T3 dose will lower serum T4. I don't know how. They mentioned that if the free T3 is low in this situation, I will increase the dosage of T3. But if the serum free T4 is too high, an increase of LT3 dose will lower free T4. So they mentioned that in many instances, adjustment of T3 dose will be indicated, and this should be done by accredited specialist. So in all scenario apart from the pregnancy, you need to adjust the dosage of T3. How to manage myxedema coma, and this question actually. So we still have a very about 80 slides. Most of them questions actually. So inshallah, I will complete this session in the next Friday, inshallah. Or we can, if we can complete in the next Friday, inshallah. So in the next Friday, inshallah, I will complete this session, and I will cover amiodarone-induced thyrotoxicosis, because amiodarone-induced thyrotoxicosis is not a big topic. So I will cover complete this session, inshallah, in the next Friday, and I will cover amiodarone-induced thyroid disorder.
Dr. Khalid,
Yes.
in your clinical practice, do you advise the combination of leothyronine and thyroxine in clinical practice?
What?
In your clinical practice,
Yes.
do you prescribe combination?
No. Actually, T3 is not available in our country, so combination therapy is not recommended worldwide, actually, except in a very little conditions. And actually, during the pregnancy is not recommended. It is safe, actually, it is safe, but it is not recommended.
Okay, it's not available in Pakistan too, but in myxedema it said now that IV.
Yes, in the myxedema it is may be used, and actually here in the management of the myxedema coma, and I will cover in the next session, inshallah, T3 can be used. Here, if no improvement within 25, T3 10 microgram intravenous. This is intravenous 4, but it can be used oral or rectally, actually, either T4 or T3.
Thank you.
Dr. Shavan asked a question: how to prevent the progression of subclinical condition to frank hypothyroidism? We have no option, actually. No rule for any preventive measurement to avoid this progression. This progression is naturally occur. Some persons will progress to overt hypothyroidism, and some patient will regress to normal. In a case of iatrogenic hyperthyroidism in patient on thyroxine, how many percentage we should reduce the dose? According, actually, if the patient have more than 1.6 microgram per kilogram per day, so I will reduce to this dosage. But actually, if the patient already in this dosage, I will reduce it by about 25% or 10%, for example. For example, if the patient in 150 microgram levothyroxine, I will reduce it to 125. But if the patient in a dosage larger than 1.6 microgram per kilogram, so I will reduce to 1.6 microgram. But don't forget that differential thyroid carcinoma need a suppressive dose, not a replacement dose. So pregnant female need a higher dose, about 2 microgram per kilogram per day, and suppressive dose may be about 2 to 3 microgram per kilogram per day. And don't forget that, and this is well covered in the next Friday, inshallah. Neonates and children, the dosage for replacement therapy is different. For the neonate, for example, we start by 10 to 15 microgram per kilogram per day. 10 to 15 microgram per kilogram per day. If the patient is symptomatic but clinically subclinical stage, then what to do? If the patient is symptomatic and subclinical, we consider a trial of treatment in this situation for 3 months. If the patient symptoms is not improved, I will stop the medication. Actually, Dr. Sadia, will we stop that? We stop then restart thyroxine in heterogenic hyperthyroidism or just reduce the dose according to the situation. If the patient is cardiac, I will stop. If the patient is not cardiac, just reduce the dose. And of course, if there is a tachycardia palpitation, we can give a small dose of beta blocker in this situation. And actually, I will cover these topics in more details in the clinical thyroidology session, inshallah. In this session, I will cover the practical aspect of thyroid disorder, not rarities. So, inshallah, I will complete this session in the next Friday. And actually, I will upload this session in the website after finishing this session. And also, I have some other actually, I will upload this one, the question and answer by the latest edition on examination 2022, and I will upload in the previous session. I upload the questions only, and inshallah today I will upload the question and answer, and also I will upload the exam lab questions only, thyroid questions only, and to be answered in the next session inshallah. اشوفكم على خير ان شاء الله، وكل عام وانتم بخير. السلام عليكم.
Thank you, doctor.
دكتور خالد بعد اذنك.
سريعا، هو دقيقه والنت رايح يفصل الزوم على فكره. لا لو كان كده ممكن تدخل مره ثانيه مفيش مشكله.
المحاضره دي اسبوعيا؟
المحاضره اسبوعيا ان شاء الله.
وبنفس اللينك وبنفس الباسورد؟
لا، في الغالب اللينك انا بضيفه على الجروب بتاعنا.
جروب؟ انا مش على الجروب بقى.
ممكن تضاف دكتور احمد زناتة على الجروب، ابعت لك الجروب يعني كده او كده. انت موجود على انهي جروب اصلا؟ انت عرفت اللينك من فين؟ انا سوهاج اندوكراين ولا
من احد جروبات الاندوكراين دي يعني. هو ده
ابعت لي ايميل واضيفك للمجموعه.
حاضر.
سلام عليكم.